myself, Dr. Dhananjay Kumar. He is also from Jawaharlal Nehru Homeopathic Medical College, Delhi. So the whole effort is, you are able to see, is the teamwork. So today, what we have gone through into the morning, now we will have a subject-wise discussion. So the presentation mode, we will have an introduction of surgery as a journal, CBDC, what is CBDC, and what is according to surgery in CBDC. Then we have got concept and outline template for the surgery. Like you have got that table, no? So we'll have brief discussion about that table, how it is being made and how to understand that table. Then teaching, learning method and media. Then integration, interdepartmental and intradepartmental. So how the subject of surgery need to be integrated with anatomy, pathology, organon, mater medica, repertory. That we will have a demonstration of that. Then formative and summative assessment, like how we will assess the student. Then our teaching hours, what are the teaching hours? 2 terms will be there. So in each term, how you have to bifurcate your whole syllabus, that we will discuss in teaching hours and distribution of the teaching hours, and macro planning is there. And finally, how we evaluate the students. So this will be the flow of our presentation. So you have gone through this document. I think the National Commission of Homeopathy has introduced this CBDC. Why the introduction was being made? Because we need an outcome-based curriculum, not pass or fail, but whatever students are getting after completing the whole BHMS curriculum, he should able to perform certain skills, certain knowledges which is required for becoming a competent homeopath. Because a homeopath serves the society, and we are able to see how the homeopathy is emerging in our current era, right? So to achieve that goal, to become helpful to the society, our student should be a competent homeopath. And for that, for the subject of surgery, how we will able to achieve that, that we will going to discuss. So the whole curriculum is made not only from teacher-centric, it is a learner-centric. So whole emphasis on how the learner has achieved the particular objective or not. So the whole document is created with this logic that a learner should be benefited. It is not for the excellent learner, poor learner, medium learner, and excellent learner. So we have to shift or travel, try to travel poor learner to the medium learner to the very good learner. And hence, the whole curriculum is dynamic. It is not static one. So we are not evaluating only pass or fail, but what skills which is required to become a competent homeopath, that we will evaluate. And so it is a dynamic. Also dynamic from the point of view of integration also, that we will discuss in our further slide, that how a particular, like our surgery topic, surgery subjects needs to be integrated with various other subjects. So it is dynamic. And that's why we will able to see integration of various subjects with the surgery. So it is very important that we try to teach our subjects in a way that the student should get this integration with various subjects, so that the whole our motive or aim should be fulfilled. So naturally, the main pillars of this whole CBDC is the end user. The end user of the whole system should be benefited. End user for a teacher, who is the end user? Student. And for the community, patient is naturally the end user. So our effort should be not just limited to pass or fail, but we should make a student to achieve certain skills which is required to become a competent homeopath. So naturally, in this curriculum, you will see the outcome based. It is not just pass or fail, but for each particular area, we have got an outcome which has been designed. So for each area, the outcome should be achievable. And specific competency should be achieved by the learner. So these are the whole pillars where the learner is the center and whole effort is being made for the learner, that the learner should achieve particular skills which is required. So naturally, our traditional education system and competency-based system, there is a vast difference. In our traditional education, it was more of time-based, that this particular topic is there, we have to finish that particular topic in a given time. Now, whether the learner has learned that topic, not only from the knowledge point of view, but certain topics are skill-based, whether this skill is achieved or not. So this is a shift, it is outcome-based. Second, it was more of a passive learning, like a lecture method. We are delivering a lecture, students is receiving. Now in CBDC, it is more of active learning. We are trying to see how the learner achieves particular skill. So it is a active learning. In traditional education, it was more of fragmented. You were not able to see any integration with surgery, with mater medica or organon. But here we have tried to make it integrated, so that a particular topic of surgery can be integrated with pathology, organon, mater medica, so that the students gets a maximum benefit of the particular topic, and also that clinically how it is important and how we integrate this particular surgery subtopic with our mater medica organon. Otherwise, what happens that our surgical topic like ulcer will remain at a level of ulcer, and some other teacher will take therapeutics of ulcer at different time. Means there is no integration, no? If we try to make an effort that we try to take ulcer topic, and finally after examination of the topic, then we teach the therapeutics, so that the learner will have got a mater medica. We try to integrate organon subject also with that, try to integrate repertory with surgery also, so that a learner can have a certain idea that these are not a separate subject. It is an integrated whole. So we will not teach a particular subject in isolation. We will have a collaboration of different subjects, so that a learner can learn in a better way. So it was more of traditional or more of a textbook driven. Now it is more of research driven. We can ask the student to search for a particular topic, ask them certain homework, so that they can able to do particular home-based work, and then they can interact with each other. So it was more of teacher-centered, traditional education. Now it is a learner-centered. We'll able to use various teaching method and media, where the traditional education was more of a textbook driven, like we take particular topic, open a textbook or deliver from that particular textbook. Now we will able to teach the topic from media point of view, like the ages of the ulcer, like how we will able to teach to the student. If we take a help of multimedia, various images, videos, then student will able to learn particular thing in a very better way. So traditional education was more of focusing on the memory point of view. Now it is a little bit, we are driving a student from, not from a memory point of view, but a higher level where the integration can be possible. So this is a overview of CBDC for the surgery. So as we all know that surgery, we encounter two various types of surgical cases from injuries, ophthalmology, orthopedic dentistry. So now how these surgical various topics can be integrated and can be taught in a better way, that is a main aspect of surgery. So as we know that homeopathy is advancing and we are able to see the various results. You know, the patients nowadays comes with your stone hai, to kya leke aayenge? Berberis vulgaris. That is very common. We are able to see in the practice कि stone है तो ये medicine आप ले सकते हैं. So homeopathy has gone to that level. So I think we can able to very well demonstrate these particular topics in our clinic also, like piles, fissure, renal stone. So our students should able to diagnose a common clinical condition. That is our objective. And they should know what is the scope and limitation of this particular surgical topic, that what case we can take and what case we cannot take. That is scope and limitation. Various suitable treatment options and when to refer the patient, how to investigate a particular case. These are the various objectives. The course outcome, I think this template is available and this is written in our template. So our basic course outcome is a student should able to take a proper history of surgical case, diagnose a particular common clinical condition, understand the role of homeopathy, whether it is purely surgical or pseudo-surgical, advise various diagnostic tests which are common, when to refer the patient, and basic dressings, basic common surgical skill like dressing of the wound, ABC management, fluid therapy. This should be taught. And integration with the homeopathic subject like what is the cause of the disease, how to manage, how to arrive at a totality, differentiate various remedy, repertorization, and coming to a remedy. So this is a basic course outcome for the surgery. So at the end of second BHMS, because it is a 2-year subject, second BHMS and third BHMS. So at the end of second BHMS, we'll at least a student should know basic surgical case taking, basic procedures like dressing, fluid therapy, symptomatology. There is a first and second chapter of clinical DAS, that common surgical symptomatology and case taking. Examination, investigation of the case, and referral criteria, that how and when to refer a case, classification and rubric hunting for the common surgical case, common surgical rubric, that can be taught, and applied aspect of Mater Medica with organon. So this is a basic learning objective for the second BHMS. Okay, so this template is available. Now we'll go to competency table. That table is available with you now. So how the whole table has been formed, that first of all, for any topic, like say for example, if you want to take a topic of ulcer, how will start teaching the ulcer? So that is, you have to design a particular objective, that is a SLO, that is specific learning objective. So do you define the specific learning objective, and that specific learning objective will fall into which domain that you should define. Then at what level it is that, like Miller's level, then Bloom and Gilbert's classification, then priority level, then integration with anatomy, physiology, pathology, organon, Mater Medica, and repertory, and teaching learning method and media, and assessment, formative and summative. So we will see the table now. So as the example is given, The content is ulcer. You can see that table that is available. So if I want to teach ulcer, how I will teach ulcer? So I have to define a particular SLO, that is specific learning objective, that I will start from definition of the ulcer, then other is given like classification of ulcer. This I have taken for to make you understand the various other aspect. So for each particular topic, you have to define a SLO. So SLO is particular objective with which you are able to explain to the student. Okay? So SLO, like ulcer, definition of the ulcer, explain therapeutics of ulcer, and demonstrate examination of the ulcer. So these are the 3 SLO we have made. So first of all, you have to define what topic you are taking, and that topic content which particular point you want to discuss. That is a specific learning objective. Like in the ulcer, what you want to start with, definition of the ulcer, then classification of the ulcer. So definition is your 1 SLO. Classification of the ulcer is 2nd SLO. Third is examination of the ulcer, that is 3rd SLO. Then therapeutics of ulcer. So for one content, you are defining 5 SLO. Okay. Then we have got to domain of competency. So domain, I think domain of the competency is given, that is the first one. So these are the set of fundamental abilities of the learner which is outcome based, and there are various subsections. So domain of competency, 1 knowledge base, 2nd patient care, homeopathic orientation, communication skill, practice and learning, improvement, and finally professionalism. So we will understand this domain of competency by an example. So first of all, we have defined a content, then SLO. कि अल्सर लिया है हमने तो उसमें ये SLO होगा. So that particular SLO will fall under domain of competency. That definition of the ulcer is a SLO, so it is purely a knowledge based. Therefore, it is written in a knowledge base. So knowledge and scholarship. Second, for examination of the wound, demonstrate and evaluate assessment of the wound. Okay, so this is a SLO. So it is a practice-based learning and improvement domain. Okay, so for each particular SLO, in what category or domain it will fall, accordingly we have written in a domain of competency. Okay, so there are 6 domain of competency. You have to define the SLO, and then accordingly this domain of competency is written. Say for example, now again in the, my content is ulcer. I will take therapeutics of ulcer. So explain the therapeutics of ulcer is my specific learning objective. So in which domain it will fall? It is a homeopathic orientation. Okay, so this domain we have, 6 domain we have kept. For particular SLO, it will fall under which domain, that is written in a 2nd column. Okay, this is clear. Can we go ahead? Now second is a Miller's level. So as in the morning session, sir has explained about Miller's level. So for particular our ulcer, content is the ulcer, SLO is definition of the ulcer. So it is Miller's, which level? Knowledge level. Okay, so our focus is that students should know what is the definition of the ulcer. So it has kept at a knowledge level, Miller's. Right. In second example, ulcer is contained, SLO is explain therapeutics of ulcer. So it is a know-how, because when we teach therapeutics of ulcer, a student has to apply his mind that in which type of ulcer particular remedy is selected, acute ulcer, chronic ulcer. So it is not only the knowledge base, but how we apply this knowledge. So it is a second level, know-how, right? In third, SLO, demonstrate and evaluate assessment of the wound. So it is a show how, naturally, it is a psychomotor skill, so it is a show how. Okay? So it is our Miller's level according to our SLO. Now we'll understand Bloom's and Gilbert. So in morning session, regarding Bloom's, sir has explained that it is a cognitive, psychomotor and affective. So what SLO we have arrived at, like for ulcer, definition of the ulcer. So according to Bloom, it is a cognitive one, okay? So cognitive is written as C. In second example, describe different classification of the ulcer. It is again a knowledge based, so it is C, cognitive. Now you look to Gilbert, that is written in a beside Bloom's /Gilbert. So in definition of the ulcer, it is a knowledge based and it is at a primary level. Student should only remember what is definition of the ulcer. So that's why it is kept as level 1. Okay? In second example, describe different classification of the ulcer where it is at the level of 2, cognitive, and Gilbert level 2, where a student has to understand and interpret. It is not only the knowledge based. A student should apply his mind that in which type of ulcer particular remedy is selected. So that's why it is kept at level 2. Now third example, content is ulcer and as well as demonstrate examination of the ulcer. It is a psychomotor where there is a demonstration. So psychomotor Bloom's, and it is level 2 where under supervision the student will be demonstrated. Like, so Bloom's classification, cognitive, psychomotor and affective. That is a classification. In Gilbert, cognitive, level 1 means student should recall, remember. Level 2 is understand or interpret. Level 3 is problem solving. These are the 3 levels in the cognitive. In psychomotor, observe, gain control under supervision and automatism, like Ryle's tube insertion. When you demonstrate, it is only at the level of Gilbert level 1. When student does under your supervision, that is level 2. And when you ask the student that do the Ryle's tube on your own, that is a level 3. So for each particular SLO, at what level you want to teach particular topic, that you define. Why you define? Because the assessment will be according to your, whatever you have taught, accordingly the assessment should be there. It should not be like that, I have not taught how to introduce Ryle's tube. In the exam, I will ask to the student that make a demonstration of Ryle's tube insertion. It happens, no? External examiner comes and then the particular question or demonstration is asked. So that's why we have to make it uniform so that all it is available that this particular SLO is demonstrated. At what level? It is level 1, level 2 or level 3. Okay, any question in this?
Definition and types and classification and clinical features. You will teach in lectures, but examination will have to be on patient. So you will be teaching them in non-lecture hours?
So you have to define what is your teaching learning method and media. If students, patient is not available, there are various methods available. On video you can demonstrate, on pictures, that is available. But when patient comes, at that time you can correlate that we have taken this ulcer topic and now you see what is the type of ulcer.
Because otherwise it so happens that whatever we have taught already 2 weeks back, and now to recall that or whatever class we have done,
Yes.
only one batch is coming to the clinic, and I have also only one batch learns. So practical hand-on training is given to only one batch, not the whole class. And subsequently, 3 months later, when the other batch comes to me, I will also forget what I had taught them, and they will also forget what I had taught them. So it becomes difficult.
Right, right. That's why the teaching learning method and media is very important. So we try to teach a particular topic which is clinical based, then we can take the help of various videos, pictures, videos.
It will be very hypothetical because ulcers I have been teaching last 20 years, and that too on our pictures, that this is base, this is flow, this is edge, this is margin. But it is difficult for them to understand and me to make them understand.
Yes.
That this is what is edge, this is what is called as margin. Margins are tightened or fibros, or it is row, or this is this. It becomes very difficult.
Difficult. So finally, learners should be taught on a patient.
Right, but then this is a lecture topic. So lecture I leave part half, examination I leave them in the lecture.
Certain like examination of the ulcer we are taking, but classification we have to teach a theory topic only.
That is fine.
So that what is a clinical classification, then we have taught.
Clinical features, symptoms, up to that is fine. But the examination, how you lift up the base, or whether it is attached or not attached, then I have to pitch it up in front of student. No?
Naturally.
Then where do I do that?
One patient.
When? Because in clinic I have only one batch.
For every clinical topic, this is a difficulty. So we have to make a solution. We have to make a solution that how we will solve this problem, because it is a universal problem. It is not our problem. Each and every teacher has got this problem that I have taken this topic, but how to show to these students.
Cyst, if I have to explain, I take a balloon filled with water and say fluctuation. This is how it is.
Very good method. So you can do this innovative method. Very good. So we have to make a solution, because ultimately some practical, or because it is psychomotor skill. If student will not able to see, then it is very difficult. If I will teach catheter on theory and I will not have.
Yes, we are teaching like that only.
Sir, this is not a different one. I think the whole idea, we have got various experience of very 20, 30 years. But the whole idea here we have kept is that we have to, for particular skill, try to teach particular skill on patient. That is a best method. If that is not available, then like pictures or videos, that we can demonstrate. And when patient comes, in 12 months we will not see one ulcer patient. That is not possible.
Yeah, that is fine. We will be seeing that. But it will be patches. That is what is the problem. One patch learns ulcer, one patch doesn't learn.
But patient will come after follow-up. If I am seeing ulcer for one time, he will not come for one time. No? Patient. So we have to track patient, like this batch, this patient has came, then another batch will try to collaborate. Follow-up में उसको ऐसे बुला सकते हैं. Because this is and this is not for homeopathy. Ayurvedic, medical, they also do like that. Whenever patient comes, then we can give them, because journals are also there. Or we can give case-based education, that is integrated medical education, our is there. So we can take that case, ulcer case, and then we can ask the student to make a history taking and examination, and then we can take an integrated lecture also.
Nowadays, often what I have done is, whenever I am seeing any kind of, say, hernia I am seeing, so I take a video of that patient with me.
Yes.
I am examining and a video is taken. And that is what I demonstrate to the other batch, whenever it is possible for them to come to the clinic and hernia is not there.
Yes.
So I show the same video to them, that last batch I had for this patient and we had examined this hernia this way, and this is how hernia is to be examined.
So this is sir has demonstrated very good method, and whatever you are seeing,
Of course,
try
with the
to
consent of the patient, of course, with the consent of patient.
with the consent of the patient. That is medico-legally very important. So you take video of the patient. That is very, very important while you are examining. And then you can demonstrate to other batch. And if patient is there, that is the best thing. Ultimately, when you see, the students see one patient, that is the best method to learn.
So, the taking this P1, P2 is very necessary for each lecture you have to make a record.
No, no, madam. So, this is a table you have got with you. So, I am trying to explain that how, what was the logic of making this topic table. So, no, no, you have got like if patient is not there, sir has told. So, I have decided that on patient I will teach this topic. But patient is not there, so you have to modify your method and technique. So accordingly you can have your track record that this topic I have taught in this way.
So, this has to be documented. We already have this chart with us. So when every lecture, every so you have to write what you have taken. In the first introductory time, then later on you need to describe what you have taken, content. Then you, I think so, ask questions to the students whether they have understood. So do we have to again write all this in a different paper for documentation?
What you have to keep is your teaching diary.
Yeah.
Student have that logbook,
Yeah.
and you have got your teaching
Lesson plan.
Lesson-
Whatever I'm saying.
lesson
Talking
plan.
about lesson plan.
lesson plan. We have not made it compulsory because this question has asked in the previous CBDC meeting.
Yeah, because it's already there. It's,
So it is not
already
compulsory
there.
for us. QCI also will, I think, that question we have asked. This year it is there. But-
the lesson plan is being scrapped.
Yes. So you don't have to worry about lesson plan.
Lesson plan is different from the lecture plan. The content is the same. Our aim is the same. That topic we teach during non-lecture or either in the lecture. Our aim is motto and contents are the same.
So you don't have to keep lesson plan now.
So in our college they say
No,
non-lecture
because
plan.
it was existing in this year. Now
So the
this
first year
first year it
it was
was there, but now it will not be. You will not be asked to have a lesson plan. Only you have to keep is your teaching diary. Students should have that lesson plan and your micro and macro teaching plan. And accordingly you are registered. Like this topic I have taken at what date, who has taken, sign off HOD. That is required.
lecture masters.
Lectures. No, what we have discussed, no, lesson plan is not, we have to keep record of. It's not required now. Yes, this year it was there, but now subsequent years it will not be there.
This first year has come to second year 2 days back. First, so from 1st of August, first batch what has come to the second year, you don't have to give lesson plan. That is what I.
It is not required. If you keep it, that is better. That will come. Further slide. Yes, I will come to that.
Before going to a lecture, if I don't have a specific learning objective of mine, it will be difficult to accomplish that at the end of my lecture. And so as to have these things, if in a written form SLOs are there, it will going to help directly or indirectly. Because when they are scrapping it out, but it is necessary what we feel is, otherwise
If you are having NAC or NAC teaching, this lesson plan is compulsory. And if you keep for your purpose, it is better, no? Because for 1 hour, which SLO I will cover up and which method I will take, that is only for 1 year we have to do the hard work. Subsequently, years that will be very easy for us to operate on.
If we are not making this, it will
is true, sir, but it is not like that if you have a lesson plan, then we will able to achieve third level. For particular topic, like we are a homeopathic college, right? So for particular psychomotor skill, we have defined that it is under observation. If students does it, that is okay. Level 3 is not required for us because for particular topic it will be there, different. So our goal is not for all level 3 achievement, right? Because certain skill they are not able to do, like surgery point of view, thyroid surgery, they will not able to do. So our aim is not like that, just a demonstration or just one patient, one student see, that is enough.
So we just have to mention the method that we are undertaking to explain the topic in our daily diet. That will be sufficient, I think.
Teaching learning method media.
No, yes, that would be sufficient, isn't it? We don't have to have a plan. आज ये किया,
Hey,
इससे बहुत
your lecture plan is required.
So lecture plan is lesson plan.
Lesson plan is not required, but in micro planning, like in which advanced teaching plan is required. So in that you mentioned which method or media you will take.
So up till now, planner what we were making for, so say August month and 3 of us are in the department. So I is Dr. Sanghavi who is taking what, Dr. Sanghavi who is going to take what, and who is going to take what, and how many lectures. Say I have 5 lectures in a month. So I will be completing those lectures in this 5 months, 5 lectures. She has or he has 8, so he will complete all those topics in 8 lectures.
Right.
Something like that, that is what we were making as a planner up till now.
Right.
So this column is to be added.
If you add, then it will be better, no?
If it is compulsory, then
See, what is the basic logic of this is that for particular like demonstration of this examination of the ulcer, in plan it is available that this will be demonstrated, right, into the clinic. So your whole team is clear, student is also clear that this particular I will see into the OPD, sir will tell into the OPD. So that is across available. So it is better for you that you will have got idea that ये topic हमको बच्चों को दिखाना है. So that change you can make. It is beneficial for your body.
So this is teaching learning method and media according to Bloom's and Gilbert. Like definition of the ulcer is my SLO. It is C1 level, and teaching learning method is lecture. So I will take a lecture for definition of the ulcer. For explain the therapeutics of ulcer, lecture or small group discussion will be the better method for this particular SLO to achieve. So whatever our SLO is there, and Bloom's and Gilbert, accordingly we have to plan our teaching learning method and media. Like demonstration of the ulcer, it is a psychomotor level 2. For this, we will have a clinical demonstration. I will not only restrict myself to only theory, but I will take the student to clinical or other methods, what sir has told, that we can have a video or pictures, charts. That way we can demonstrate. So I think DOPS and OSCE, these two things are there. DOPS is used for your procedures, like for learning like suturing, Ryle's tube, catheter. These are all procedures. So for learning any procedures, you adopt DOPS. That is direct observation of procedural skills. So our SOL is demonstration of examination of the ulcer. So you can have all these options. You can do a small group discussion, you can do OSCE, you can do DOPS. So whatever you are comfortable. Here we have not limited to that for this SLO, you have to do OSCE. No, it is not like that. It is, you have to decide that for this particular topic, SLO, which method is the best method according to your availability of patient, student strength. That way you have to decide. No, it is only knowledge based only. No, video manner will not be, we have to, no, so DOPS is not observation of the video. Mhm. Mhm. But for particular SLO, the demand is that we should demonstrate to the student. Then what we will do? It is requirement. We have to forget about our limitation. We have to see our best method so that students should achieve a particular SLO. Demonstration of examination. We have to demonstrate to student, no? So here it is written, it is not compulsory that you adopt DOPS. DOPS is generally used for procedures. But for particular topic, it is advisable that you demonstrate and then discuss. So for that, DOPS is less or not possible because it is a DOPS is generally used for procedures. But certain, sir, examination of the ulcer you are taking and slough is there, you will remove that. So it is not a definite demarcation for a surgeon, no? अभी हम अल्सर देख रहे हैं, साथ में ड्रेसिंग भी कर रहे हैं. So we will not limit a student that अभी आपको यही करना है. Right, no? So whatever you have done, you can write DOPS also if you have demonstrated a particular skill. Like अल्सर का आप ले रहे हैं लेक्चर, अल्सर का डेमोन्स्ट्रेशन हमको करना है, साथ में अल्सर इज इन्फेक्टेड, सो यू विल ड्रेसिंग ऑफ द वुंड, सो दैट इज अ डायरेक्ट ऑब्जर्वेशन. डॉप्स हो गया वो, राइट नो? सो वी हैव केप्ट डॉप्स दैट इन अल्सर यू कैन हैव ऑल वराइटीज, यू कैन डेमोन्स्ट्रेट ऑल्सो certain procedure in this, so we have kept. But it is less likely because it is not a typical procedure. For all procedure, you can use DOPS. Now, how to make a DOPS? That is a second question we have interacted. So there are in surgery, there are various books are available. So I will forward the books in our group. That is literature is available. So you go to that and you can have the idea that how the particular DOPS has been designed in a tabular form. So that you can, OSCE is also available. Books on OSCE is there. Only the homeopathic part is not there. Clinical part is there. No, I have got name of the books. Soft copy I am not having. This group. We have made a group, WhatsApp group. So in that group we will. I think OSCE sir has. So please share. Okay, so please share into our group. OSCE sir has demonstrated with one example into the morning, that is observed structural clinical examination. In OSCE, it covers all your aspects from case taking, case receiving, case processing, examination, investigation. So you can make OSCE for this also. That is not, it is not mentioned that for this you have to make this only. It is up to the particular lecturer that it is not compulsory.
Have you ever recovered from abscess ulcer? If yes, then how will you greet the patient? How will you make him sit and how will you demonstrate and how will you try to see? And how will you note down the observational findings? Worried about the ages and all these things, they will come at the third level. But at least at these four categories they have been doing,
particular skill you have to demonstrate or learn to the student. What sir has told that you start with your how you greet to the patient, consent of the patient, uh, your revealing your name, your identity, that I am doctor this and this, I will do this examination. So all these points you have to mention.
Then this will become a station, no?
Station, OSCE station.
तो ये एक में preliminary data station हो गया, एक में clinical history
History taking हो गया,
एक में therapeutics
examination हो गया.
Nowadays, with absence of patient, we have to have a simulated patient. That is the key concept. Tell one patient that you are suffering from an ulcer, and that other student should examine. That is what we are trying to do. I don't know the better way how, if the patients are not there, how to do. Yeah, simulated patients are there. So I am simulating you. You behave like this, and let the other person will take, and we are going to observe and do the treatment.
So this OSCE you have to make.
And then for particular step 1, step 2, step 3, step 4, how many minutes you are designing, like orienting to the patient for the particular procedure or skill, 1 minute. Introduction of doctor, 1 minute. Case taking, 2 minutes. Examination, 2 minutes. Then ordering investigation, your repertorization. Likewise, you have to mention the various steps and your minutes. And in examination of the patient, of the student, that minute should be given to the student. Like 20 minutes for particular OSCE is there, then you have to give that minute to the student. We have to keep the record. So use of this is directly on the assessment. So we have defined the SLO, like definition of the ulcer. Our method is lecture. Naturally, our assessment will be the either from formative it will be viva and summative will be MCQ based. Second, explanation of therapeutics of ulcer. Teaching learning method, lecture or small group. Assessment will be viva or MCQ, SCQ or LAQ. So it is a logical connected. Whatever is your SLO, it will be define your teaching learning method and media, and accordingly you have to define what is your assessment. Formative and summative. In second year we have got formative assessment only, no summative assessment. For demonstration of examination of the ulcer, clinical demonstration, OSCE, small group, DOPS, your assessment will have this only. So whatever your teaching learning method and media, your assessment should be parallel with that. Okay, there should not be any fracture in that. So that's why the whole idea of using the teaching learning method and media, you can take that for particular topic, you will ask in theory or you will ask into the viva or your clinical examination. No theory.
Yes, for formative we have to be only in the viva or OSCE or
Viva and practical, clinical examination.
next year summative they will going to extract 5 months out of this into
So how this mark will go into the third year, that I will demonstrate. So formative and summative assessment, I think sir has no theory exam, sir. But this topic can be asked in third year, no? Third year also. Because in third year we have got a... Yes, we have got general surgery paper, no? So all these are topic of general surgery in the second year. So for second year you have to take this formative assessment. In third year you can take this as a summative assessment. What? PA and a TT, no? So we will come to that aspect. So we will come to that assessment. That will come. How we will assess, what are the marks, that will come. So I think this is clear, no? Assessment, formative and summative. Now most important, integration. What madam has asked, how we'll integrate the various topics. So it will again depend upon what is your SLO and Bloom's and Gilbert's classification. Like for definition of the ulcer, C1, now we will have a definition of the ulcer, but primary from pathology point of view, if student is not aware that what is ulcer, because in the second year ulcer is there, no? General surgery. So it will be difficult for you to teach that particular, if you not integrate your ulcer with the pathology. Inflammation, acute inflammation, chronic inflammation, ulcerations. So that you have to integrate. Then and then student will be able to have the integration with the pathology.
No, no.
That must be aligned with the pathology lecture also. That must be aligned. The concept is 80% analysis has to be there and only 20% integration. If pathology is teaching ulcer and simultaneously surgery is also teaching ulcer, it will be aligned.
एक घंटे में कैसे दो दिन पढ़ेगा?
So
I will just brief out whatever discussion has, whatever you are feeling integration means. Teacher will be, yes. So what you feel you should do? You will ask that pathology teacher to come, or you will, yes. So integration, you will integrate yourself with pathology. Okay. What you will do, sir? That is also okay. So, okay. Okay, so there is a second. Okay, any third, any suggestion, other? Sir, madam?
Sir, injuries have been given 10 hours. So I was planning 9 hours, I'll take 1 hour, I'll ask 50% to just come and speak on it. So that is also okay.
not on
Sir, injury topic has been given 10 hours in surgery. What I've did, cursory reading. So 9 hours I might take and 1 hour I might ask my colleague from FMT just go and elaborate on more regarding, because integration is FMT with injuries.
So you will ask FMT
Yeah.
teacher, no?
Yeah, just 1
So
hour
that
if
is
it
one.
is 10 hours.
Any other idea? Because we have to think. Nobody other will think how you have to teach this particular topic in a based manner. So if pathology teacher is free, if he can come, then it is okay. It is not that we will not invite him. If it is not, so So 2 points are coming. Very good. So this is the third point. But it is only that 1 hour you are having, that once a week there is integrated teaching, no? In curriculum it is there. So what you are talking, that you can take particular topic, or you can have a case-based discussion. You select particular case which has got all dimensions, surgical dimension, organon, mathematics, right, pathology, and then you can have that meeting also with the students. Okay. Second point, what madam has told, that we are not, अभी हम जो कर रहे हैं वही करना है ना आपने. अभी हम कोई टॉपिक लेते हैं, पैथोलॉजी से स्टार्ट करते हैं ना हम लोग. सर एनाटॉमी सिखाते हैं ना पहले प्राइमरी, तो हम इंटीग्रेट नहीं करते हैं. We are integrating. Here it is not that a other teacher will come and sit in your lecture and do the integration. Here it is, if teacher has to be integrative with all the subjects, because we are doing that. ऐसा नहीं है कि हम करते नहीं हैं, हम थेरेपेटिक्स के लिए मैथमेटिका ही लेते हैं कि हम लेते हैं. थेरेपेटिक्स कौन लेता है? खुद ही लेते हैं ना, तो हम मैथमेटिका इंटीग्रेट करते हैं. मैं तो भी बताता हूँ.
ये बाद में देखेंगे इनको.
Yes. So here the logic and concept of integration is that each teacher should have the integration within himself, because our subject is not fractured. No? We have to integrate surgery with pathology, mathematica, organon, and that we are doing. So we have to do this integration that we are doing. Second integration, if it is possible, what sir has told, अभी उनके पास availability है, pathology के teacher free है, तो हम अपना time अगर वो sir आके
We can take the clinical meeting with the guest presentation with all allied government, that is what teachers.
yes, so that 1 hour is there.
That is what our integrated teaching.
Yes, so that integrated
Teaching is there, 1 hour separate. How we can do that, I will demonstrate. But this point, I want to demonstrate that 2 methods are there. Whatever best is available, you can do that. So teaching learning method for theoretical topic and for non-clinical topics. These are the list of teaching learning method that you can employ for purely theory, lecture, small group discussion, integrated lectures. For non-lectures, clinical demonstration, PBL method, case-based learning, various assignments you can give, library reference, self-learning. This is possible for non-lectures. So this is a gross division of teaching hours. In second BHMS, we have got 92 hours, 24 non-lectures hours. In the list, it is given 60 hours. But now we have reduced to 24 hours. So you follow this, non-clinical 24 hours and theory 92 hours. So for each term, you will have 58 hours of theory and non-teaching, 12 hours and 46 teaching hours. So, see, for particular, like if you want to teach a student therapeutics of ulcer, अभी आप पढ़ाएंगे, उससे अच्छे आप स्टूडेंट को बोलो कि जर्नल में या तो थेरेपेटिक के बुक में एक ग्रुप को 5 ड्रग दे दो, दूसरे को 5 दे दो, तीसरे को 5 दे दो. So it is a library reference. Student will go to the library, they will actively do the work, and then you sit and you have got a presentation by the team of students, and then you guide. So this is a way of teaching the topic. आप डायरेक्टली हम पढ़ाते हैं ना, अभी थोड़ा सा हमको देखना है कि कैसे स्टूडेंट को एक्टिवली इन्वॉल्व करें. यस, बिकॉज स्टूडेंट विल लर्न. अभी हम एक ही मेथड में जाएंगे ना, तो स्टूडेंट लर्न हमारे लेक्चर के बाद 10 या 20% ही लर्न करता है. अगर एक्टिवली हमको कुछ टास्क देंगे ना, दे विल एंगेज मोर. हाँ सर, ये रेफरेंस के लिए है. रेफरेंस के लिए आप ये कर सकते हैं. कम नहीं होना चाहिए, ज्यादा होगा तो चलेगा. So this is a timetable, rough timetable. So you will have 2 lectures in second BHMS and 1 OPD, IPD, casualty, OT. अभी आपके पास 100 का बैच है, तो आपको 2 बैच करना पड़ेगा, तो ये एक्स्ट्रा होगा उसमें. तो 2 थियरी और 1 क्लिनिकल. that will suffice your hours need according to NCH. So your rough calendar, because in the August second BHMS will start. आपका हो गया start अभी या it will go? हो गया ना अभी. So you can have this PT1, PT2, TT1, TT2. This is a course content term wise that is available in our template. Soft copy is there, you can download easily. So this is hours wise distribution. I think this is also given, no? ये भी है. तो आपका ऑल मैक्रो प्लानिंग तो अवेलेबल ही है, आपको थोड़ा माइक्रो प्लानिंग करना पड़ेगा कि ये 3 आवर्स हम कैसे लेंगे बस. हाँ जी. अच्छा, नहीं ऐसे तो 12 आवर्स के 12 मंथ्स के आगे तो आप एग्जाम ले ही नहीं सकते.
I think 12 months are required.
6 to 7 months.
According. हाँ.
12 महिन्यात एक्झाम होऊन रिझल्ट लागला पाहिजे. जसं फर्स्ट इयरचा 18 महिन्यात एक्झाम होऊन रिझल्ट लागला पाहिजे. हो. 1 ऑगस्ट पासून त्यांनी सुरू केलेलं आहे आणि एमसीएचं म्हणणं असं आहे की तुमचं कमेन्समेंट 1 ऑगस्ट त्यांचं अकॅडमिक कॅलेंडर यू हैव टू फॉलो देयर अकॅडमिक कॅलेंडर नॉट योर्स. तुमको लगेगा कि तुम्हारे प्रिंसिपल लगा चलो 15 अगस्त चालू करते हैं 20 से चल ऐसा चलेगा नहीं.
खत्म नहीं होगी तो बच्चे आएंगे कैसे? जब फर्स्ट ईयर की एग्जाम चलेगा सेकंड ईयर में आएंगे कैसे?
हमारे तो हो गए, हमारे चालू हो गए.
So you have to make your arrangements accordingly, because if 12 months are there, then you have to do 5.5, or 5 months. But for documentation, 6 months will be required.
So this is clinical hours. This is also available. So this is a Viva examples of the ulcer. Like you can ask what is ulcer, what is tropic ulcer, what is healing ulcer. These are the Viva question. MCQ, you can have this MCQ, SAQ and LAQ. This is only example because we have to create whole list of MCQ, bank of MCQ, SAQ and LAQ. वो हमको बना के पूरा ग्रुप में डिस्ट्रीब्यूट करना पड़ेगा so that uniformity will be there. Very good. So please circulate in our group. So details of assessment, I think this is also available in our booklet. So PA1, PA2, PA at the end of 3 months, 9 months, TT1 and TT2. TT1, 6 months and 12 months, TT2. So according to your time availability, you can 5.5 months आप कर सकते हैं. So in 100 marks clinical or Viva, this is also given that 50 marks will be of purely of Viva. Other 50 marks, 25 marks is for surgical case taking. That is compulsory. Okay, so you make sure because this documentation can be asked. 25 marks surgical case taking and other 25 marks for the your examination of the wound, dressing, basic life support. You have to ask for 25 marks. In other TT2, 50 marks of Viva and 50 marks, 30 marks will be of surgical case taking, examination of surgical case, and 20 marks will be of your surgical 5, that is journal. So journal 20 marks. Second year it is 5. Second year it is 5. हाँ सेकेंड ईयर में 5 किए हैं, अभी थर्ड ईयर में शायद 15 कर सकते हैं, हो सकता है अभी. इट इज़ इन अंडर प्रोसेस, थर्ड ईयर इज़ अंडर प्रोसेस. हाँ अभी कर रहे हैं हम लोग, तो अभी शायद पॉसिबिलिटी है कि 15 करेंगे तो 20 हो जाएगा. आपका कोई सजेशन है तो बता सकते हैं, ऐसा नहीं है. सेकंड है, हाँ सेम जर्नल कैन बी कंटिन्यू. अलग भी रख सकते हैं, कंबाइन भी रख सकते हैं, बिकॉज सेकेंड ईयर में अगर फेल हुआ बच्चा तो उसको संभालना पड़ेगा जर्नल. आपका जैसा करना है कर सकते हैं. So how you will calculate marks in third year? So in third year, PA 1, PA 2, that is A and D, marks of PA 2, marks of TT 1. So you have to make an average. So this is the calculation D plus G divided by 2. Now this assessment you have to keep in your record, because at third year when you are arranging the marks, that time this will be required, and this documentation is required. You have to keep a record of this.
Bracket on PA1 plus PA2. But otherwise it will be considered as 30 marks, 20 plus 10. PA2 divided by 2. That means PA2 divided by 2 is not like that. PA1 plus PA2.
हाँ yes, PA1 plus PA2 divided by 2. हाँ हाँ ब्रैकेट कर दो. अच्छा अच्छा, कैलकुलेशन. So now, any question further? Integrated teaching, learning, 1 hour is there. So you can use that 1 hour in either case-based method. So you can select a one case which is treated in our OPD, and then you can take that case, make an objective of that particular case, directives, and then you can distribute amongst the student, and then you can have a meeting with all the teachers. So you can do this integrated teaching. If you want a demonstration of how we can do, that is available. That is not compulsory for today's discussion. But if you want, we can have a demonstration of that. Otherwise, my lecture is over.